Heavy drinking doesn't just harm the liver, it often walks hand in hand with depression. When these two conditions collide, they reinforce each other in ways that make recovery more complex but also more urgent. Let's start with a truth that just gets overlooked far too often. Alcohol and depression don't just coexist, they feed off each other. And for many people, this isn't a temporary overlap. It's a cycle that can last for years unless both conditions are addressed head-on. Now, this might sound familiar if you've worked in mental health or addiction services. Maybe you've treated someone whose drinking worsened after a breakup or a job loss, or someone whose anxiety spiraled into depression and then into nightly drinking. These are not isolated cases. They're backed by numbers, and a lot of them. So let's look at the prevalence. Nearly 1/3 of people with major depressive disorder also have an alcohol use disorder. And for people who are alcohol dependent, their risk of major depression is up to 4 times higher than in the general population. Some studies have even found that up to 64% of people who are alcohol dependent meet the criteria for clinical depression. So the link is strong. But it's not just correlation, it's causation in both directions. So let's break down the two-way street. Firstly, alcohol leading to depression. Alcohol is a central nervous system depressant. It disrupts neurotransmitters like serotonin and dopamine, which play a key role in regulating mood. Over time, heavy drinking lowers the brain's ability to naturally balance these chemicals. Think of it like this. At first, alcohol provides a sense of escape or euphoria, but with repeated use, the baseline mood actually drops and it becomes harder to feel anything positive at all without drinking. That's not just a theory, it's been shown in brain imaging and neurochemical studies. But there's more. Alcohol use often brings serious psychosocial consequences. People might lose jobs, damage relationships, withdraw from support systems. Each of these increases emotional stress, which only deepens depression. So you're left with a chemical hit from the alcohol and a psychological hit from everything it disrupts. Now flip it. What happens when depression leads to alcohol use? This is what researchers call self-medication. The person feels overwhelmed, numb, or hopeless, and they turn to alcohol to cope. At first, it might feel like it helps. It dulls the emotional pain. But again, that relief is temporary. And often, it reinforces the cycle. Feel bad, drink to feel better, feel worse, drink again. Longitudinal studies back this up. People with depressive symptoms are significantly more likely to develop alcohol use disorders over time. Not occasionally, consistently across studies and populations. The research suggests that moderate drinking doesn't increase the risk of depression in the same way, but when it becomes frequent or heavy, the link is clear. So the issue isn't drinking per se, it's why, how often, and in what context it's being used. This leads us to the big picture, quality of life. When someone is dealing with both alcohol use disorder and depression, the impact is severe. People report worse outcomes across the board, psychological, physical, social. They're more likely to be unemployed, to live in unstable housing, and to experience chronic illness. They're more likely to feel hopeless and less likely to access the help they need. And when they do seek help, the treatment journey can be more complicated. So let's talk treatment. In the past, mental health and addiction services often operated in silos. One team treated the depression, another treated the alcohol use. But that approach often falls short. If you only treat the alcohol use without addressing the depression, you risk relapse. If you only treat the depression but someone continues to drink heavily, medications might not work or might make things worse. That's why integrated care matters. This is known as dual diagnosis care. Research shows that combining cognitive behavioral therapy, CBT, with motivational interviewing, MI, is particularly effective. CBT helps patients identify unhelpful thought patterns and behaviors, while MI focuses on building internal motivation to change. Together, they offer a structured, empathetic way to tackle both conditions. Here's a case-style example to bring this to life. Imagine a 35-year-old man named Sam. He's been drinking every evening for the past year after a divorce. He says he feels numb and can't sleep without a drink. He's also showing signs of major depression, low mood, lack of energy, suicidal thoughts. In a traditional system, Sam might be referred to a substance use clinic, but his depression goes untreated. Or he's given antidepressants but told to cut down on the drinking on his own. With an integrated CBT and MI approach, Sam works with a clinician on both fronts. He learns how his thoughts and emotions lead to drinking and starts to build healthier coping strategies. He's not judged, he's supported. Over time, his alcohol use decreases, his mood stabilizes, and he starts to see a future again. Now multiply Sam's story by the thousands of people experiencing the same pattern. That's the potential for integrated care, dual diagnosis care. And it doesn't end when treatment ends. Aftercare and ongoing support are crucial. That might include group therapy, relapse prevention planning, family involvement, or check-ins with a GP or a psychologist. The aim isn't just sobriety, it's sustained mental health and social recovery. Another clinical angle to consider is medication. Some people with depression need antidepressants. But here's the problem. Alcohol can blunt their effectiveness. In some cases, it can make symptoms worse. That's why reducing or abstaining from alcohol is often recommended during antidepressant treatment. This is also why screening matters. If a patient presents with depressive symptoms, clinicians should always screen for alcohol use and vice versa. Tools like the audit, Alcohol Use Disorders Identification Test, or PHQ-9, the Patient Health Questionnaire for Depression, are simple, validated tools and are widely available. So let's ask a few direct questions because this is where prevention starts. Are we asking our patients with depression about their alcohol use? Are we screening for mood symptoms in people with known drinking problems? Are our treatment plans addressing both conditions together? If not, we're missing opportunities to intervene earlier and more effectively. There's one more point to touch on: stigma. People struggling with depression often feel ashamed, and add in alcohol to the mix and the shame doubles. This stops people from reaching out. They might be afraid of being judged, or they've already internalized the idea that they've failed in some way. So part of our job, whether we're clinicians, educators, or peers, is to challenge that stigma, to say clearly these are common, treatable conditions, and there's nothing weak about asking for help. So let's revisit the key points before we wrap up. Depression and alcohol use are bidirectionally linked. One increases the risk and severity of the other. Heavy and frequent drinking is associated with significantly higher depression rates. The relationship involves neurochemical, emotional, and social mechanisms. Integrated treatment, dual diagnosis care, including CBT and MI, is more effective than treating either condition in isolation. Reducing alcohol use often improves mood and sometimes reduces the need for antidepressants. Persistent depression may still need targeted therapy or medication. Screening, ongoing support, and stigma reduction are essential. And finally, help is available. The cycle can be broken. Whether you're a healthcare professional supporting patients or someone personally affected, the message is the same. Change is possible. But it starts with recognizing the whole picture, not just one part of the problem. That's all for today, folks. My name's Dr. Ferghal Armstrong, and this has been Cracking Addiction.